SI joint that's being opened up. So let's go to the apiaxial SI joints first. Now, a big star where that little bomb signal is right there. Make sure you know that for apiaxial SI joints, we are going to do an angulation, cephalic by the way, cephalic angulation of 30 for males, 35 for females to accommodate for the different pelvis design between male and female. Now, supine is going to be preferred. Can you do this standing? Yeah, but I wouldn't recommend doing it standing. It's going to be kind of hard to get that good little angulation that you want if they're sitting up against the bucky because you have to be so low with the bucky in the tube. So go ahead and lay them down on their back, legs extended. You can kind of bend them as well for comfort if need be. Still a 40-inch SID. Now you will see sometimes on the questions and the material, they do have that range of 30 to 35. Make note, that doesn't mean you can use that entire range. It's just telling you it's basically between 30 and 35 between male and female. Don't let that fool you or mess you up. Once again, 30 for males, 35 for females. Please do not forget that. We're going to enter along the LSP and be 2 inches below the as is. Another one of those little centering points that's easy to forget. Make sure you know that, 2 inches below the as is. And we're going to use a 10 by 12 lengthwise cassette. Now, of course, we are going to collimate slightly as needed, depending on the size of the patient's pelvis, because we are only interested in the SI joints, not the pelvis. And it does recommend doing a 6 by 6 collimation at least, but that is variable depending on how wide the patient's hips are. Now, the breathing, it says suspended, but make sure you make note that's suspended on expiration once again, because we're in the abdominal area. So we're always going to rely on the expiration technique when it comes to abdominal areas of the anatomy. And shielding is going to be gonadal for males only. Now, they do not give you an option of shielding for females on this one because even though you could utilize an ovarian shield, unfortunately because of where the ovaries lie, it'd actually be really close, if not on top of the SI joints themselves. So we're not going to opt for shielding on females, only on males for these SI joints. So little fallopian tubes do hover up a little bit further. They're going to be nearer on top of those SI joints.
This one's just hold your breath.
This is suspend on expiration, as is every exam this section. So everything's basically abdominal, so we're going to rely on that expiration principle.
So your friend said it was only the L spines that were expiration.
It's still on these two. Trust me. That's what they're asking, trust me. And once again, just make sure you remember that you're really paying close attention to those names, those positions, guys. I say it a lot, but repetition is good for the memory. When you see the word axial, you know there's got to be some kind of angulation on there. And remember that because when we go to the obliques, there's not going to be an angle anymore. We're just going to oblique the body. There's going to be a perpendicular central ray. So look to the name. It's going to kind of reveal to you what that angulation should be, that there will be an angulation versus perpendicular central ray. We'll see here in a minute. All right, so what do we want to see? Of course, well, it's an SI joint x-ray, so we need to see both SI joints, by the way, because this is a bilateral exam. Apiaxial is bilateral. The oblique, when you see in a second, is going to be a unilateral exam. So for apiaxial, we're going to see both open SI joints. We accomplish that by adding that angulation of 30 or 35 degrees cephalic to open up those joints further. Also, because we are adding that certain angulation, it's very close to one we talked about last class, that Ferguson method, that we're also going to open up the L5-S1 junction or joint space. That confirms that we added that correct angulation to that exam. Of course, collimate to the part. You don't want that wide open. We're just worried about SI joints. We're not worried about the rest of the pelvis. Of course, add your marker, as you see right here. And make sure those 3 joints are open. So that's something easy to forget, guys. Even though it's SI joints, technically we want 3 joints open. We want the L5-S1 and then the left and right SI joints to be opened up for this particular exam. It's almost like a trilateral exam when you think about it. They don't actually call it that. I just kind of threw that in myself. Trilateral.
Another question.
Is that a left marker?
Yes, it is.
Why is that also?
It's sideways.
That's funny.
They put it horizontal. actually looks very similar to what we'll see as a sacrum X-ray. When you think about it, it's done very similarly actually to a sacrum X-ray. All right, now we're gonna go to our AP oblique SI joints. By the way, these are only ever done as an AP obliques. Therefore, we only ever do LPO and RPO. We do not do REO, LEO under any circumstances for oblique SI joints. It's a great thing to write down. Also, a great thing to write down, put a star on, is another thing people often forget on this exam is that this is not a 45-degree oblique. It's very easy to default to that 45-degree oblique because it's the one we do the most. Please make note for SI joints in particular, that is going to be specifically a 25 to 30 degree posterior oblique. Now that range, you can use either one between 25 and 30. It doesn't really matter between male and female, just whichever you want to do. Make sure you do support the body with the sponge if you have it available. And the IR is going to be centered at the level of the as is. We'll talk more about that in a second when it comes to centering on the central ray. By the way, central ray, we're not to it yet, is going to go to perpendicular. Please make sure you remember that when you go from the axial to the oblique. That's another thing people make a mistake on and forget about. They forget to adjust that tube accordingly to make it a perpendicular central ray for the oblique. Reason being that we're relying on the body now to open up that joint as opposed to using the actual angulation on the tube to open up the joint like the previous exam. So supine only. RPO and LPOs only. By the way, you can expect to have 45 degrees as an answer choice. I'm warning you now, don't pick that answer. See if I get at least one of y'all on that question. Yes?
What's the side of interest if, like, let's say their left side is down, is the right side going to be of interest, or is it going to be?
Correct, which we're going to see in a second. We always focus on the upside on this one. So we're opening up the elevated joint on our obliques. And there you have it. That's what we're talking about right there, guys. So once again, perpendicular central ray. That's going to enter the patient 1 inch medial of the elevated as is. So this is where this can be a little difficult because I know some of us are still having trouble finding the as is. Make sure that you are centering at the as is and not the top of the iliac crest. As is slightly inferior to that area. Once you find the as is, you're going to move 1 inch medial to that elevated area. So you do center on the upside because we are interested in the upside, as you can see right here. We are visualizing the elevated joints. Collimation should be at least 6 by 10 or 6 by 12. It's whatever your preference will be. You do want to collimate down to that one joint. I know a lot of techs will leave this one open as well. It's kind of pointless because you're actually closing the opposite joint. The downside joint's closed, the upside joint is open. We're only interested in the open joint space, not the closed one. So you not only want to center on that open joint, you want to collimate down to it specifically to help it really pop on that x-ray.
So 6 by 10 or 6 by 12?
Either one. You have a range you can choose from.
Will both be answers? Will both of those be answers?
I wouldn't put both as answers. That would be very nice. All right, so once again, guys, what are we looking at? Now it's a different bit of wording there, it means the same thing. It's saying the sacroiliac joint or SI joint farthest from the IR, that means the elevated or the upside, that's the joint of interest. And what do we want to see? Of course, the open SI joint with minimum overlapping of the ilium and the sacrum. We also want that joint to be centered to the radiograph, which we're slightly off-center on that x-ray there, but pretty close. But you can see they collimated down to just joint of interest. But once again, I see a mistake on this one a lot. People will put their centering on the downside, and that's just a waste of time because that joint's actually closed. We want to be on that upside because that's the joint that's actually opening up with that obliquity that we're administering for that exam. So just make note of that different wording. Always look at different wording because they can ask that same question in many different ways. If they say joint farthest from the IR, that's the same as saying the upside or the elevated side. The more complicated way of saying it there. Don't let that throw you off. Yes?
So with this image, is this a RPO to look at the left? Is that why the
You are
left
correct, very
marker?
good, that's an RPO. Yes.
But you marked left with the
You
left.
mark the site of interest.
Okay,
Yes.
thank you.
That's a good thing to write down too. Thank you for bringing that up. You do mark the site of interest on the oblique SI joints. So, yes, so I know there's a lot of variances because we change those rules a lot. It really depends on, basically, as I always say, who's the star of our show, what are we focused on? That's gonna determine a lot of times what we mark. So please be careful, you see a left marker on an SI joint. It's an oblique, that means it's an RPO. You saw a right marker, it tells you it's an LPO, so we're looking at that elevated side. Very easy to make a mistake there. All right, that's going to allow us to now segue to the sacrum and coccyx x-rays, in which we have two AP axials, one for the sacrum, one for the coccyx, and they are going to be vastly different from each other. They're actually kind of opposite of each other, as you should know from lab. Then we have the laterals, and keep in mind, even though you see separate laterals for sacrum and coccyx, we're going to go over each one separate, but most of the time, per most protocols, in fact, every place I've ever worked, this has always been the protocol, usually do the lateral of the sacrum and coccyx together. Even though we're going to learn them separate, often they're done together. Also, usually whenever it comes in the hospital, they'll order both AP axials as well. We wouldn't with both. That's typically the protocol. Now, big note here, and of course, I know this is likely not going to happen because we can't always control this, and let's be honest, they're probably not going to tell the patient to use the bathroom before this exam. I recommend if you have the time and the ability to, have them use the bathroom. Bowel should be prepped and bladder empty before the exam. Why? Because think of the area we're x-raying. If there's urine in the bladder, if there's feces in the colon, that's going to obscure what we're trying to see. It's going to be right on top of the sacrum and the coccyx. It's going to really reduce the image quality overall. So as a general rule, we're going to go ahead and have them use the bathroom prior if we can do that. Also, as I said before, a lot of times people come in for sacrum and coccyx pain and they're just constipated. They just need to have a bowel movement, but it feels like it's in that area. It might be the tailbone, coccyx, whatever you want to call it, sacrum, and they're thinking it's some kind of spinal issue. You know, I just need to go to the bathroom. Question?
Mr. Donahue, is prep the same as emptied?
Yes, prep means you see the empty bladder, empty colon. Or if you want to use the actual scientific terms we use in fluoro, for bowel, we're going to evacuate the bowel. For the bladder, we're going to void the bladder. Void for bladder, evacuate for bowel.
Or can they be put on NPO for the whole day?
No, they wouldn't be on NPO. We're just going to try to get them to use the bathroom just because the general area gets obscured by gas and feces and urine, everything in between. All right, so AP axial sacrum, you notice it says supine only. We are not going to do these standing. They must be lying down on the table. Now, you do have an option between supine and prone, but please make note, once again, when we're talking about quality and the superior position, we're going to opt for supine every time unless it's just physically impossible. Why? Think about how that body part lies in the body. If we're doing prone, what's going to happen? What's going to happen, guys? For prone. A lot of OID. Think about where your coccyx and your coccyx and sacrum, almost said tailbone. I'm not supposed to use that word anymore. Coccyx and sacrum are located. They're extraordinarily posterior. Can't get my directions right. Posterior, so we want that close to the IR. If we do prone, we're elevating that body part by quite a bit, especially if the person has very thick hips. And it's going to really magnify that body part we're trying to see. So, as a rule, you should always do supine. That's optimal. That's the best way to do it. But if you have to, you're going to reverse the direction of your angulation. So for prone, and I'll show you in a minute what I'm talking about, we're going to change the direction of our tube angulation. Now, part position, we want the MSP, of course, in the midline, as is equidistant from the grid, if we're using a grid. Arms comfortable and out of the way. And go ahead and support those knees if they're supine. Have them slightly bend the knees. That's also going to put that body part even closer to the IR. It's also going to help them if they're having really bad lower back pain, as an injury like that can obviously cause. So you'll see in the picture his legs are straight, but I would go ahead and have them bend the knees. It's just going to give them more comfort, help them hold still for you. Question, Jay?
You said as is equidistant from the grid. Would you recommend that we use a grid?
Well, you should anyway if you're using the table. I mean, there's a grid in the table. So, if you're doing it free cassette, so let's say you're doing a portable, then you'd want to use a grid, yes. Very thick area of penetration once again. Help clean up that scatter.
What's the technique that you would use for, like, let's say a normal static patient? Like, here.
Like a normal sphenic patient, like what technique would I use?
Yeah, like KVP mass.
For this guy right here, I'd probably use 90 kVp at about 18 to 20 mass. But that's using the machines I used to use. There's variances between the machines. You gotta be careful with that.
We'll just ask the type
You get a lot of variances on the machines, on those KVP and mass techniques. So if you're taking notes on those in clinic, just be wary that that probably will change if you go to a different facility. All right, so for central ray, guys, now please put big stars on these when we're talking about sacrum versus coccyx, because this is something people always forget. When we're talking about sacrum, it is a 15-degree cephalic angle. That's going to be the opposite when we do coccyx here in a second. 15-degree cephalic angle if we're supine. Now, you'll see under that, we do have a caudad angle if they're prone. Now, what did I say? We should always opt for supine. That's optimal, but if for some reason they were to ask you the prone position, make note, it does reverse the direction. So supine, 15 degrees cephalic, prone, 15 degrees caudad. Now, where's the central ray? 2 inches superior to the pubic symphysis. Now, should we palpate the patient's pubic symphysis? No, we should not. That's not appropriate. Where are we going to palpate to find that centering? The greater trochanter, correct. If they can, he'll wiggle that foot, find that greater trochanter. That's basically at the level of that pubic symphysis. We're going to go 2 inches above the pubic symphysis. And then 10 by 12, the book does say you can go ahead and leave that open. Me personally, I'm going to go ahead and collimate a little bit. It's not a huge body part. It's going to help optimize that image if you collimate down a little bit. But 10 by 12 is considered acceptable for the collimation on this exam. Great picture there, guys, showing you once again the different angulations, cephalic for sacrum, caudad for coccyx, which we're going to go over that one here in a minute. So why do we add the angulation? You might be asking yourself internally, or maybe you're not, I'm going to tell you anyway. Because of the way the pelvis itself is shaped and the way that the sacrum and coccyx curves in the body, whether we're male or female, there is a curve to that body parts. We add the angulation to the sacrum and coccyx to elongate the parts. So we're adding some distortion to the film. We're elongating the body part to give us a better visual of it overall. Because if we just did straight down, like we do for like a normal pelvis, you may notice on a pelvis it's kind of hard to see them. They're kind of foreshortened looking. It's the way they're curving. So we add that angulation to further elongate each of those body parts. So it's a case of distortion working for us rather than against us. All right, what do we want to see on an AP axial sacrum? Well, what's the exam even saying? It's a sacrum, therefore we want it free of superimposition. That's what we add that angle for. It brings it out of superimposition and elongates it. Look how big that sacrum looks. That's what we want to see right there. And this is a beautiful x-ray, by the way. They do not always look this nice. Beautiful collimation, beautiful angulation. I mean, that's nice. This person really does need to go to the bathroom, but you can still see pretty well overall what we're trying to see on that x-ray. Sacrum centered and in its entirety. By the way, if we do not utilize a 15-degree angle, we are not going to see it in its entirety. It'll actually be cut off down here. We're not going to see it very well at all. We want the sacrum free of foreshortening. Foreshortening naturally occurs if we don't add an angle. If it's a perpendicular central ray, it will be foreshortened and cut off. Pubic bones not overlapping the sacrum. By the way, if we add too much angle, if we go beyond 15, we're going to see that the superior rami will be on top of the sacrum. It's going to actually obscure all that sacrum that we want to see. So it has to be that exact 15-degree angle. You'll have a range there. No rotation, of course. Make sure they're in a true AP, which can be challenging if they're having really bad pain in their back region, their lower back region, their buttocks area. They're going to be shifting that weight on you. So make sure they're lying nice and flat for you. Also help them bend those knees again to help the comfort overall. Do not put sheets or pillows under the bottom. Why? Think about how you're shooting your x-ray. You're shooting through those sheets and pillows, you're gonna have a big artifact on your film. So unfortunately, they have to lay on that hard table, especially for this exam. We cannot put anything underneath them. Not even a sponge, by the way. Sponge will still kind of obscure what we're trying to see. So you just tell them to deal with it. Stop crying and take it. Come on, take it like an adult. No, please don't bring patients to that.
HR.
With kids, just tell them, stop whining, get over it. No, you never say that. Even if you're thinking it inside your head, you never say that. No one's ever thought that before, right? I'll just stop whining, get over it. I got a job to do.
Or like, if you would loosen up and let me push your button, I would be done.
It's good to learn to keep internal monologue internal.
That's why I
A lot
say,
of
thank
times, right?
gosh we have to wear masks now because I'm constantly
I
like.
can't see your expressions. It might be changing in May though, because we're clearing everything over. I think the hospital's gonna,
Well, can I still keep my?
I think it's still like an option if you want to, but they're not gonna require it anymore.
Because I make faces. Especially if
You gotta
I'm
work on that
walking,
poker face. We
I
always say about the
can't.
poker
There's
face.
some of them that I just don't even-
I know, it can be, I used to have a lot of trouble hiding my expressions.
Can you see you know how the people say you can see like their smile through the mask?
You can.
Can you see a grimace through the
Yes,
mask?
you can.
Really?
Look at the eyes.
So if I'm like,
Yeah, an entire person's reading through their eyes.
okay,
Yeah,
Yes, you
that
can.
time that I walk into that.
If you pay attention to such things. Watch how the eyes dilate, watch how the eyes wrinkle and rise and fall. Pupil dilation can tell you a lot about what a person's thinking. Seriously. I'd say the eyes are the window of the soul, they really are. No one's ever noticed pupil dilation?
I don't think I stand that close to people
Yeah.
and look at their pupils.
You don't have to stand close to them.
Oh, I don't-
you can also look at your significant other and
Well,
if
I
they
look
get
at
like
him.
real big.
She's like, I look at him.
You know, they often say when your pupils dilate, you really like somebody.
Oh.
It's like the window of love. You know? They say you're attracted, like if you watch, if someone's looking at you in a conversation, their pupils dilate, they get big, that means that they like you. Now everyone's gonna be looking at each other, right? That's,
Look at
John.
if that, guys, if their pupils get very tiny, you know, back off.
Yeah.
All right.
It's like, you like me or you're on drugs?
So you didn't know you're gonna learn about relationship advice next year at school too, right? Yeah. All right.
Learning how to see through people, I see you.
That's right. Psychology, it's a powerful tool. Okay, AP and PA axial coccyx. So we're going to do this almost the exact same way. The only thing that we're going to alter, of course, is the direction of our tube angulation. Instead of cephalic, we're now going to do a caudad angle. We are still going to choose supine over prone for the same reason that coccyx will heavily magnify and distort if we do it PA. So there really is no reason you should ever do a prone unless, once again, the patient's just physically unable to. Let's say they come out on a trauma stretcher, they're PA, they're prone, you can't touch them, they want a sacrum and coccyx x-ray. Well, obviously you'd have to do it prone then, but if they can be on their back, that's the superior optimal way of doing it. Keep that in mind. Once again, positions is exact same as sacrum. We're just going to change that angulation, guys. We're now angling 10 degrees caudad. Now be careful because that goes from 15 to 10. Will Mr. Donahue put a 15-degree caudad on your chest? Yes, he will. Because you have to know that. Not because I'm mean, because you need to know the difference between those two. That's where they'll get you on the registry with little numbers like that. It's a 10-degree caudad angle. Once again, why? To elongate the coccyx. Think about how tiny it is. It's very tiny. It's the size of a postage stamp. We want to elongate it on the x-ray because that's now the star of our show. Gives us a better visualization if there's a fracture on that tiny, tiny bone. The centering is the exact same way. we are still 2 inches superior to the pubic symphysis. Now be careful, because what a lot of people make the mistake on is they'll do their AP axial sacrum first. Like, well, I'm already centered to the pubic symphysis, let me just change my angle and we're good to go. Why is that a bad idea?
Because you're not centered to the eye.
You're not going to be centered to IR when you change your angulation direction. You have to recenter. I've seen so many people do that. Be very careful. You have to recheck your centering between the 2 exams because the direction of the tube changes. So obviously we have to recheck that centering again. 2 inches superior to pubic symphysis.
So like during capstone, we can't just.
No, you gotta, capstone, you gotta center that cassette. That's probably one of the things that get people the worst on capstone is centering to their cassettes. Whether we're doing free cassette, wall, or table buckies. I feel like people nail the positioning overall, but man, that centering that tube to that cassette gets a lot of you guys. Got me in school too. That was my Achilles heel. My teacher, she used to tear me apart about that. I swear she tore me up so much though I never made the mistake again. Like, she gave me head trauma, literally. She used to hit me on the head with a clipboard.
We're gonna do our capstone in the new lab.
Hopefully,
Hopefully,
if we get it up and running.
Hopefully, it's tracking.
Hopefully it's cracking.
Hopefully, it's tracking.
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 They said cracking.
Cracking out.
Let's get cracking. I mean, that is a saying. So,
So it's technically fire for AP?
yes. And then prone, you would do cephalic. Yes. But once again, in red, that's the main way you're going to do it, guys. Now you'll notice the combination field is much tinier, 8 by 10. I still argue that's a little bit large for a coccyx X-ray. Now this is one of the ones where you can do like one of those super pro techs, like do that really narrow slit collimation. And man, let me tell you, if you nail that X-ray with that tiny collimation, it looks good. It looks really good. But you gotta be careful, very, very careful.
Where would you put the marker at? Like in
Where
the
would you put the
bookie?
marker? Like if you're doing super tight collimation?
Mm-hmm. Like for this, since it's so tight.
You guys gotta kind of put it, well what I would do is I would put it kind of like as medial as possible towards the lower portion of the cassette. Because on the X-ray, the coccyx is going to be a little more superior and elongated. You kind of have that space down at the bottom, so you can afford to put that marker more towards the midline on the lower margin of the cassette, if that makes sense.
Okay.
So,
We can put it
in other words, I'd put it down here. We don't need to see any of this. This is the star of our show, so you can put it down here.
Okay.
That's what I would do. Make sense?
Not in the curve of this coccyx, sir.
What about it?
Not in the curve of the
No,
coccyx.
no, don't put it in the curve of the coccyx. It's going to be in the anatomy. Yeah, you're safe putting it down here. All right, so who's the star of our show? Now it's the coccyx, therefore it must be free of superimposition. Also should be centered, not superimposed by pubic bones, no rotation. And we do need to see it elongated as we see right here. That nice elongation, showing that coccyx completely free of superimposition. It's compensating for that natural curve, so we get a good, nice look at it. Most of your coccyx x-rays will not look this pretty. Why? Once again, people are very gassy. They gotta go to the bathroom and they never do, and it covers it up kind of bad. So if you get a really ugly coccyx x-ray, like there's a lot of black right there, keep in mind that's pretty normal, because a lot of people are just having pain down there because of constipation and gas, not necessarily a cracked coccyx. But that is what it should look like. You see right there. Excuse me.
Did you say it's the size of a post-it note or a post
Size of a postage stamp.
stamp? That's
Yeah,
very small.
Very small.
The coccyx?
Mm-hmm. Y'all remember the picture I showed you?
Mm-hmm.
It was on the lecture.
Yes.
So some of y'all were paying attention, the other rest of you were checked out during that slide. That's,
Well, I knew it was like this big.
it's very, very small. Very easy to break.
It hurts so much, huh? The smallest thing hurts so much.
It's like
Usually
your
they can't do
pinky.
anything about it.
Yeah, I mean, you got little nerves going through there too, so very painful. Like I said, most of the time, people tend to get that injury like in skating rinks. You lose your balance when you're skating, you go backwards, you fall on your bottom, hit that coccyx, very painful.
I thought it was going downstairs.
That's another
Like
one.
they slip.
That's another one. But man, those roller rinks and ice skating rinks, it gets people's tailbones. Mm. Especially me, 'cause, man, I cannot skate to save my life. I've got no balance. I'm the person like hugging the wall the whole time. Seriously.
I thought you
had
said
those
you were a
little
skater.
I am not a skater. I need one of those
His,
things, yeah.
his son is.
My kids can skate pretty good. Man, I'm terrible at it. I just got no balance. I got vertigo in my ears too. It doesn't help. So
You get you a
my,
little
Because you're
my
really tall.
equilibrium's really bad.
I think it's because you're tall too. Like, I
Probably.
feel like short
It's
people are
awkward.
way better than.
I've noticed
tall
that.
people.
It's really awkward for tall people to skate. All right, so lateral sacrum, once again, we're gonna go over each exam, lateral sacrum, lateral coccyx separate. Keep in mind, per most protocols, you're gonna do these together as one X-ray. I think that's how y'all do it in lab too, right? Y'all do it together in lab? But do make note, the book does separate them. Okay, so for the lateral sacrum, that's gonna be a recumbent lateral only. We're gonna lie them on their side, preferably the left side. Hips and knees flex for comfort. That helps them stay in that true lateral as well. Make sure the legs aren't straight out. They're gonna roll all over the place on you. Arms at a right angle, knees superimposed. And do that walk around on your patient that I always talk about, guys. Make sure the shoulders and the pelvis are actually in a true lateral. So if you walk around, you see the shoulders rotated, you might think, well, I'm just looking at the sacrum and coccyx. It doesn't matter if those shoulders are rotated. Well, yes, it does, because if the shoulders are rotated, the entire spine shifts. That's going to take even the sacrum and coccyx out of a true lateral. So they must all be in that exact same plane. And once again, if they're having lower back pain, what do people do? They shift that weight. You got to be really careful and make sure they're not moving on you. Of course, sacrum centered to the IR. That's the star of our show. I'll show you the actual centering to that on the next slide here in a second. You'll also notice what's behind the patient again. That lead shield. What's the purpose of that lead shield?
Reduce back scatter.
To absorb the scatter and help optimize that image. Just like that L5-S1 joint space, this is probably one of the thickest areas of the body that we penetrate, thus we're using a very high mass on this. Thus, because we're penetrating so much tissue and using high mass, the scatter is going to be higher. We need to clean up that scatter, helps our image look so much better. I know many of your techs won't do this, but I'm telling you, it will really make your images look so much better if you add that shield behind the patient. It really does make a difference. All right, where's the central ray go? Well, keep in mind, because we're now out of the axial realm, we're back to the perpendicular realm. For lateral, we do not use an angulation. It's a perpendicular central ray. We're at the level of the as is again, and we're going to go 3.5 inches posterior to the as is. Why? Well, look where the as is. Look at where the sacrum and coccyx are. They are posterior, therefore we need to go posterior to make sure we're actually penetrating the sacrum itself. So we find the as is and we move 3.5 inches posterior to that point to center for a lateral sacrum only, by the way. This is not when they're together. Lateral sacrum only.
So instead of being like MCP, we move back a little bit.
Well, you're not going to use the MCP, you're just going to use the as is, which is more anterior than lateral. Keep that in mind. MCP is going to be in the center right here. As is anterior to that. So you go 3.5 inches posterior to the as is, not MCP.
So there's not gonna be any light in front, it's gonna be. in
There
front.
shouldn't be, no. Where would you put, where I put my marker? Well, I always leave a little bit of light behind the buttocks. That's a good spot to put your marker for that exam. By the way, be careful where you put your hands when you're staring the patient on this. I'm just saying, because I know we like to check, make sure if you are in true lateral, don't be, palpating their butt or anything. Be careful. Because what people will do is they'll palpate here, then they'll move their hand back here. Just be careful. Be mindful of people's modesty. Don't be creepy. Yeah.
This is kind of obscure, but is this one of the furthest distance from a landmark that we have for an exam?
It is one, yeah. Yeah, we don't use 3.5 too often.
Yeah, it's usually 2, or I think the highest one we have is 4, right?
If I'm not mistaken, 3.5 is usually the max we'll do on centering. I don't think we
What
have.
about
I don't think we have 4.
the chest X-ray?
Well, I guess technically that's almost 4. Yeah, I didn't think about that one. It shouldn't go beyond 4. I don't think anything goes beyond that. 3.5 to 4.
So we'll always have the landmark within 3 to 4 inches.
From what I can recall off the top of my head, yeah. All right, so lateral coccyx, this is gonna be slightly different. So we're doing the same exact position as the sacrum, but our centering is gonna be slightly different. We're still gonna find the as is, but we're gonna go 3.5 inches posterior and then 2 inches inferior to the as is. So right now a little bit of inferiority to make sure we're focusing on the coccyx and not the sacrum. Very close collimation needed for this one. Once again, think how tiny the coccyx is, and that lead rubber once again to absorb that scatter. Even though it's a tiny body part, we're still penetrating a lot of tissue right there. Once again, be mindful how you are centering. Watch where your hands are going for this x-ray. I would recommend you eyeball it more so than touch the patient. Very modest area, so be careful.
Don't eyeball too hard.
Also, I mean, like I said, that lady I used to work with, she'd just stick her hand down there and palpate the coccyx. Don't do that. Don't do that. Yes.
I have a question, since, we do both of them together, the sacrum and coccyx, what would you send it at, since we do, you know?
Help refresh my memory, but I believe the sacrum and coccyx is a very similar centering when they're together, if I'm not mistaken, correct? Is that how y'all did it in lab? 3.5 posterior, 2 inches inferior? Is that how y'all did? How'd y'all do it in lab? Because we teach it separate in the book, but in lab, I know we do it a little differently. In clinic. Y'all don't remember what y'all learned in lab?
That was many days ago.
It wasn't that many days ago. Less than a week ago. I'm pretty sure it's centered the same.
The same?
And then just open up the collimation to include both.
Okay.
Yeah. But this is talking about just coccyx, by the way.
Mhm.
Make note, in the book we are learning them separate. All right, so for sacrum and coccyx laterals, of course, we need to see the sacrum and the coccyx interlateral. No rotation. Make sure those knees are on top of each other and bent. Make sure the entire body is interlateral. You check the shoulders and the hips. Make sure they're all in that same plane. And then that's what a pretty nice one will look for you right there. It does have quite a curve to it. But this is an x-ray including both, as you learn how to do it in lab.
Did they center a little high?
No. If anything, they center a little bit too low.
Too low.
It's all the space down here.
There's a little bit of rotation of this,
Very slightly. You can see right here.
Oh.
And you can look at the acetabulums.
Yeah.
So they probably had the patient probably shifted the hips a little bit when they took this x-ray. Y'all see what I'm talking about? See those two acetabulums, they're not superimposed.
Are those the ala that connect to the coccyx or the sacrum? Up at the top, like right underneath that? Those two shadows right there.
Yes.
Yeah, what are those?
That's the greater sciatic notches. All right, so our last exam we're going to go over is the scoliosis radiographs. Now, we're going to learn these in the way that most facilities do them, in that they will stitch or partition the images together into one singular image. But make note that some facilities, especially some of those in Harris Health that do not have the algorithms on their computers, they'll do these exams separate and send them as like a series of spinal x-rays. But truly what we should be doing is actually stitching these together into one image. I'll show you what I'm talking about here in a second. So for a typical scoliosis exam, it may or may not include the four you see there, a PA or AP upright, PA, AP upright with lateral bending, lateral upright with or without bending, and a PA or AP recumbent. Now most commonly what they're gonna do is just a plain PA upright and a plain lateral, both standing. Now, great registry question, and I know this is a registry question because this is reported to me by a student, and it has been on their review this year. For radiation protection and safety purposes, should we do a PA or AP scoliosis x-ray?
PA.
PA, but why? That's very important to know.
like for females to protect the ovaries and the.
Protect the ovaries, protect the testes, protect the breasts. A lot of these are done on teenagers, so developing tissue in the breast area is very sensitive. Also the thyroid, the thymus, the eyes. Always when it comes to protection purposes, guys, whatever part you want to protect, you want to put it away from the central ray. It'll be facing the other direction. That's a general rule. Now scoliosis, as you can imagine, because we're taking the entire body, it's gonna be a very high dose x-ray. So preferably we want to do these PA to protect the patient. Even though there'll be some OID because of the location of the spine, safety does supersede the quality on the scoliosis. That's a great thing to write down. Safety supersedes the quality on scoliosis x-rays. Now, why do we do these? We're going to look at the amount and degree of curvature that occurs with the force of gravity acting on the body. Scoliosis is affected by gravity. That's also why we prefer to do these standing to see how gravity is impacting the spine. Also, if they've had fixation devices such as Harrington rods, y'all remember those pictures I showed you with all the rods on the patient's spine? Those are called Harrington rods. They'll do these x-rays to make sure that those are holding firm and the spine is not continuing its curvature with the scoliosis condition. Now, they will also order the bending study specifically if they want to differentiate between the primary and compensatory curves of the body. That's basically the concave versus convex curvatures we talked about at the beginning.
Excuse me, sir.
Question?
What do you mean by primary and compensatory curve?
What I just said, the convexity and the concavity of the spine. That's just another way of saying the same thing.
What did you say about the shielding? The shielding.
So I wasn't exactly saying shielding, I was saying make sure you face the body away from the primary beam on scoliosis, because most of the time we do this on children and teenagers, and safety does supersede the quality. So we want to do PAs preferably on these. There are types of shields we can administer now that you brought up shields. If for some reason the doctor is demanding they do AP only, what you should do for this exam in particular, you won't do this for most x-rays by the way, but for scoliosis in particular, because the dose is so high, we're going to administer breast shields. Those do exist by the way. Breast shields and gonadal shields on the front of the body if an AP is used. You know, most facilities unfortunately don't have these, so stick with the PAs. Even where I worked at TCH, with the amount of these that we did, we didn't have breast shields to use, so we'd always do them PA. But those do exist. All right, so for scoliosis, there's a variety of devices and IR holders we're going to use. It depends on the technology that the facility has purchased. Also depends on the program or the algorithm the computer uses to stitch those images. So, optimally, when we do these images, we want them to be combined or stitched, or another word to add to your vocabulary, partitioned. Combined, stitched, or partitioned by the computer system to create one singular image. When it says note special radiation protection, that's what we're just talking about, guys. Based on PA, if they must be AP, we want to use gonadal and breast shielding. Gonadal and breast shielding. If you want to know what those look like, they look like little pads that come to the sides. They actually have two little holders. It's like on two little stands. And the little breast shields just obscure the breast while leaving the spine exposed.
What kind of technique would you use for scoliosis?
So for scoliosis, even though I always hate the use of AEC, you want to use AEC for this one. Why? Because you're holding it down the entire time. You're not going to adjust the technique at all. You're going to let the computer do all the work. So for this x-ray, once again, if you have the correct algorithm and equipment in your hospital, you're going to hold the trigger down. The computer is going to detect the patient and take several exposures by itself as you hold the button down. So you're literally just holding it down, tube's going beep, 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 and then it stitches everything together. One long exposure. Pretty cool, actually. A few places at Harris Health have that. You'll see if they ever use it.
think Matthew said there's one at the golf game.
I believe so. And that's what it looks like, by the way. This is a device they stand on, and this thing right here helps the computer be able to track and detect the patient to make those multiple exposures in one shot while also stitching it all together. I forget what the exact name of this is, but this is the exact same one I used to use at TCH. The computer will be able to detect this, and it makes those various exposures, stitching them all together. Also has this ruler that you do have to utilize. The ruler must be on your images because the doctor uses that ruler to measure the degrees of the scoliosis going on with the patient. So it must be upright. We're not going to do this lying down, facing the vertical grid for protection purposes. MSP centered, as is equidistant to the IR. Arms abducted and not in the field. What I typically will do is have the patient hold on to these two handlebars right here. That's what they're there for. Have them hold the arms out of the way. If the arms are in the image, it's going to mess it all up. So arms abducted out of the way, not in the actual field of view. Now this is a big problem right here. This person should not have a shield right here because they're actually they're not gonna be able to see the whole spine. It's gonna cover up what they're trying to see right here. What they might be doing is just like separate images and moving that, but because they have this device, it should be tracking. It's just kind of funny, it's sticking out to me, it's incorrect. You cannot do that.
So we shouldn't shield even if like the first couple images aren't gonna be.
If you're doing them separate, you do shield, but if you're using a device that stitches them together, you cannot shield. We're gonna do them PA. Now, the only case where you would probably be able to use a shield is if you're doing an AP, you're using the breast shield, like I said. There's also little gonadal shields you can stick on the patient. Have y'all seen those before? The ones that stick to people? It kind of looks like 3 little circles. I don't know what that shape is, but you can put it on the patient's pelvis and it sticks to them. I think I have a picture of it. I'll show you what I'm talking about. Otherwise, you're not going to use gonadal shielding, though. Central ray perpendicular, even though that tube's going to move all over the place. Centering points for each sequence will be dictated by the system that is used. It depends on the computer, it depends on the algorithm, it depends on what it detects during the exam. Depending on how tall the patient is, they will acquire those stitched images in a 2 or 3 image sequence. So like I said, you're going to stand them up just like you see there. Hold the button down, computer does all the work for you. It's going to make 2 or 3 exposures, and it's going to use the algorithm to stitch them all together into one singular image. Collimation, variable depending on the system you use. Some algorithms require you to have the field wide open. Others allow you to collimate down. If you can collimate down, obviously we want to collimate down. It's going to make the image better, plus protect the patient. But once again, that's variable depending on the system you're using. There's all kinds of different programs and algorithms that you can purchase. Some are better than others. Depends on how much your facility wants to spend on that particular program. Much like CT, you purchase algorithms per the parts you're visualizing. You have 3D virtual algorithms. You have angio algorithms. You have brain algorithms. You have all these different computer programs that allow you to get the best possible picture in what you want to see. That's kind of where X-ray's heading towards as well. Kind of how I was telling you about that EOS system, how to kind of predict where X-ray's going to go towards. We'll be purchasing all these programs and algorithms to maximize the part we want to see.
So we don't
Boy,
have-
vendors will have fun selling those.
You talking
They
about
cost
that
a
one?
pretty penny. Huh?
The one that we talked about on Friday?
I'm talking about the EOS, but the
Oh.
one you showed me would be similar. It's an algorithm that you would purchase. Just like you're purchasing a piece of software for your computer, guys, same thing. Of course, since it's medical, we're talking about like tens to hundreds of thousands of dollars.
So
They said
that
that
big
machine was 1.2 million.
That was 1.2 million?
Yeah.
Doesn't surprise me, 'cause it's brand new. Yeah.
So if that becomes a thing, we won't have a job.
Oh, we'll always have jobs. Like, I don't care how good the technology gets, you're gonna have to always have human presence monitoring it.
But if it's like you don't even you say you don't need positioning and stuff for that, right?
You still gotta run the machine.
We still have to say thank you for choosing Harris
That's
Health.
right. That's right. I don't think you have to worry about that in your lifetime. That'll probably be beyond your
Check two
lifetime.
before you do, you know what I'm
John,
saying?
you safe, you safe.
If I'm safe, we are safe.
Yeah, if you safe, we're safe.
Now, make note, when it comes to what we wanna see, guys, it's quite a long range. We wanna see the entire spine from the base of the skull all the way to the tip of the coccyx. So basically the entirety of the spine from top to bottom. Now, it always says base of skull because, well, the mandible's obscuring about half the C-spine. So base of skull and the tip of the coccyx. By the way, that's the shield I was talking about. You can stick on the front of the patient. That's a gonadal shield that will stick to the patient's front side if you have to do an AP. Not every facility has those. I've actually never seen one in real life. Now, of course, you want to see cervical, thoracic, and lumbosacral spines, vertebral column lines. I will add as well, because it's not on here and it's not on this image, you do need to have that radiographic ruler showing as well. The radiographic ruler showing on the image so the radiologist can measure the degree of the scoliosis.
And you said it wasn't on this image?
It's not on this image, nor is it on here, but I know for a fact that's part of the criteria
Okay.
if you're using that particular device. You have to have the ruler on there. And if you look closely, you can see where the image was stitched. Can you see it?
Mm-hmm.
Yeah.
Right here? But it's pretty flawless when you look at it really close. It's pretty cool how the computer can do that. Yes?
You don't give any breathing instructions for this?
Nope, you just tell them to breathe normal on this one.
How does it not show like orthostatic breathing though?
It's an advanced program.
Okay.
It is. It's an advanced algorithm. And one thing to keep in mind, you think about everything that we do in X-ray that is a factor that brings quality down. With every program and advancement that comes out, it further mitigates those existing issues. So as we see this technology get better and better, it's always going to improve upon the things that are detriments in the past, which is pretty neat to think about. It's not what CT does with each advancement. CT always has an issue with what we call contrast resolution, spatial resolution. So every new software that comes out, every new program, every update will further mitigate spatial resolution until hopefully it's non-existent anymore. Every new program that comes out with X-ray, things like movement, breathing, artifacts, each new software, each new digitization, each new software we use to manipulate images afterward are going to further mitigate things like breathing and movement and artifacts and stuff like that. X-ray suffers with contrast resolution. That's also going to improve with each new update in software. It's kind of fascinating to think about. I'm going on a whole tangent there.
No,
but
you're
you
good.
follow me.
Do you think we're gonna get colors as like
That'd be cool.
The step before we get to like holograms and whatnot?
Well, the EOS does the colors,
Oh,
so we're basically there. It's just not really affordable yet. All right, so of course, guys, alongside the AP or PA, we must do a lateral. So that's going to be an upright lateral. Once again, this image is inaccurate because you would not have that shield there. That's going to mess up your stitching process. You do want the arms up and out of the way, because if the arms are relaxed, well, guess what I'm covering up with my arms? My entire spine. I got to get them up and out of the way, just like with a chest X-ray. And oh, there it is. Special ruler. Ruler needs to be adjacent to the spine as well. These little handlebars do raise and lower. As you can see, they raise this one up. Excuse me, so the patient can bring the arms up out of the way. Excuse me, hiccups. Yes, question?
So the patients for the scoliosis are tall? Because the
Are they
man-
tall?
Yeah, because the man was also tall and this one also.
They don't have to be, they can be any height.
It's just a coincidence that these are tall people, the people that are.
Yeah, that is a pretty tall person, because that's like,
This one and the man was also.
that's
very
like
tall.
almost 6 feet, how high that is, so. Just a tall patient, but they can be any height. Yeah, it doesn't matter.
It kind of looks like the floor of a table. You know how it like.
Yeah, it does a little bit, doesn't it? Yeah. That's a GE system. You can tell by the coloring. GE always has those distinct colors, that beige and that off-white.
But this one isn't in like the regular X-ray rooms. This is like.
This can be in a regular X-ray room. Yeah, so once again, it's a software combined with hardware. This is the hardware. You install the software on the computer, and then your tube can do this auto tracking and get these X-rays. All right, so central ray, guys, still perpendicular. Centering is going to vary once again by the sequences and the system, and it's still going to be a 2 to 3 image process to acquire those images and stitch them all together.
So for a PA scoliosis errors, it's 2 images, and for lateral,
It's 2 to 3 for both.
Okay.
It depends on the patient's heights. So I can tell you probably this patient, because she's rather tall, that'll be a 3-image sequence, most likely. Then you'll get a pediatric about this tall, guys, and sometimes you can just get the pediatric all in one. Depends on the height of the patient. It's variable. Go back one. Now, as you can probably realize, in comparison to your PA and AP, on the lateral, we will get the entirety of the spine from C all the way down to L and S. Because of course in the lateral C, we're not gonna have the head obscuring it. All right, so there we go, guys. There's our evaluation criteria. Once again, entire spine from base of the skull or the occipital bone, if you want to be specific, to the tip of the coccyx. Entire CT and LS spines. And of course, our vertebral column aligned properly down the center of the image. And this image right here, they failed to have the ruler again. Bad barrels. There should be a ruler right there along the back side of the patient. They also centered this way too anterior. This patient should have been moved back. It's a very thin patient too. This is all wrong. It's bottom. Move that back. By the way, if you want to know what all those little cross hatches are, that's how the algorithm knows how to stitch the images. It uses that little cross pattern on the computer. And you'll see 2 markers. Why are there 2 markers?
2 images.
Because it's 2 images stitched.
Where's that B?
Hmm?
Where's the B in the corner?
There's a B. Oh, yeah, that's for image B. Figure B. You don't add a B. It's not B for butt. If you wanna- That's where the buttocks is. You don't know.
No, that was funny.
Huh?
That was funny.
That was pretty good.
You got us laughing on a Monday. That's how it
Hey, that's yeah.
You know it's funny when John tells
Getting
you.
better.
something.
Better with the jokes. Okay.
You better take
There's
that
some-
and run with
There's
it.
some hope.
You better take it and run with it.
All right, so we'll go ahead and take our first break, guys, because we're going to do some